guys, and welcome back to another episode of the Dr. Perkins podcast. So today we're going to be talking about neuroleptic malignant syndrome. So what you can see is you got this young lady, she's very, very agitated and so on, and it's because she has neuroleptic malignant syndrome. So what's happening here? Well, this young lady, she was on a dopamine blocking agent, right? And so that's one of the major criteria that you see here. And so what's happening? Well, usually we get on these agents because you have some sort of psychotic issue, right? Some sort of psychiatric issue. So you might be schizophrenic, you might be anxious, you might be depressed or whatever. And so a lot of times we'll get on these agents. Now, another thing that can happen is you do the reverse of it, right? So you might have Parkinson's, where the problem is you're trembling because you don't have enough dopamine, right? And so you're taking your Parkinson's medicine to get enough dopamine to take care of this trembling, and then you stop. Well, out of nowhere, it's like you went on a dopamine blocker, right? Because your brain's used to this high of dopamine level, and now it's just plummeted, right? One other thing to mention before I get off this is another dopamine blocker that people go on is often nausea. Right? So a lot of women get severely nauseous in pregnancy, right? You get hyperemesis gravidarum, morning sickness. And so they're taking these meds, they're going to block the dopamine receptors to treat their nausea and vomiting. Okay, so one of the problems that happens is if the dopamine level goes too low in the brain, it's like you have Parkinson's. And so that's why you get rigid, right? Because your body's acting like you have Parkinson's because you don't have enough dopamine. All right? And so what they believe is happening right here is because we're blocking those D2 to D4 receptors with our antipsychotics, first generation is the worst generation. They're the most likely to cause issues in terms of this neuroleptic malignant syndrome. You don't have enough dopamine to do what you should be doing. And so what's happening is you're producing lots and lots of glutamate. And so now your body's getting really excited. That can be kind of like a seizure right there. And so you're very, very tense because you have very, very high levels of glutamate, right? Well, what happens if you start clenching up all your muscles? Well, number one, you get muscle rigidity, but the other thing is that's going to create a fever, right? When you exercise, you can easily burn, 10 times, easily, just even taking it pretty easily, 2, 3, 4 times the amount of energy than just sitting there. And so if you're like this, you can create a fever very easily. I remember as a teenager, I would go running. It'd be 30 degrees outside, and I'd be sweating like a hog, sweat dripping off my fingers, nose, and toes. Why? I'm easily creating 10 times, 20 times the amount of body heat than just sitting there doing nothing. Okay, so that's where you're going to get your fever. The other thing that's going to happen is the D2 receptors in your brain are very important for kind of shutting down your sympathetic nervous system. Well, if that's not there, sympathetic nervous system's in overdrive, right? You're getting ready to beat somebody up or run away real fast. I remember in high school and stuff like that, sometimes I'd get very nervous when I had to talk in front of people. And so I'd wear a sweater and stuff like that because the AC was cold. But when I got in front of people, I often had to take off the sweater because it was so hot. Why? My sympathetic nervous system's going into overdrive, right? So they really took it to the extreme. And so you need all of these major criteria to be diagnosed with neuroleptic malignant syndrome, right? And so it's a beautiful name describing exactly what's happening, right? You're on a neuroleptic, you're on an antipsychotic, right? That's just a fancy way of saying antipsychotic. It's a syndrome. It's a collection of signs and symptoms. And it's malignant, right? It's really bad. It's really dangerous. Neuroleptic malignant syndrome has about a 10% death rate if managed well. If not managed so well, it's not unheard of for it to have a 20% death rate. Now, here are some minor criteria for this neuroleptic malignant syndrome. So you can be mute, right? If you have really bad Parkinson's and you're just having trouble starting motor activity, right? You're going to have trouble talking. White blood cell count is going to be elevated. Why is that, right? Well, one of the things is if you're very stressed, right, or you're very physically active, you're going to be releasing a lot of stress hormones, and that's going to actually move the white blood cells from the side of your blood vessels back into circulation, right? Give an example of when your body's under extreme stress, being in labor, it's not unheard of for you to get white blood cell counts up to 20,000, right? Well, this is a lot more stressful than labor, and so it's not unheard of to have a white blood cell count up to 40,000. All right, the next thing you got is your labile blood pressure, right? And so if you're like this, right, you see how I'm tensing up and relaxing, tensing up and relaxing. Well, what's going to happen? Well, when I tense, my blood pressure needs to be a lot higher than when I relax, right? And then I'm releasing all these stress hormones and everything else, right? And so not unheard of for your blood pressure to be at least, systolic blood pressure to be at least 25% higher than what is normal for that person, right? Or the diastolic blood pressure to be at least 20% higher than what's normal for that person. And then the label, it just means it swings up, down, right? Contract, relax, right? That's what's going to cause those swings right there. All right. And so, yeah, for it to swing by 25%, not uncommon. All right. Altered level of consciousness, right? We've got all this dopamine that we're not getting. Then on top of that, your body's extremely stressed. Got all this going on. You also tend to get dehydrated. Why? Because the heavy sweating from all this muscle activity producing the high fever itself stopping your brain from kind of working, right? Once again, not unheard of 102, 104, right? And so you're not going to be thinking the greatest. All right. Then on top of that, incontinence, right? So one of the things is because of all that glutamate activity and that epinephrine and norepinephrine levels are very high, it's not unheard of for this thing to cause you to have a seizure. One of the side effects from seizures is you pee yourself, right? Increased creatine phosphokinase. All right, what the heck is creatine phosphokinase to begin with? So your muscles, they cannot store enough ATP in the muscles for them to lift something heavy, right? Then on top of that, let's say you're trying to lift something heavy, right? You got the sugar that has lots of ATP, but I can't get it like that. So, how do I bridge that gap? Well, what happens is store all the energy, store a lot of energy that I can use in a time of emergency in the form of creatine phosphokinase. So I broke down my sugar, produced ATP, or broke it down fat, produced ATP, and I'm storing the energy from ATP in the form of creatine phosphokinase. I go to lift something heavy, I break the energy out of creatine phosphokinase, put it back in the ATP, and that's giving me time for my aerobic respiration to kick in, and so now I can create the ATP and so on that I need, right? Well, if I'm using the muscle really heavy, right, I'm all kind of cramping up and so on. What's going to happen is my muscles are going to start breaking down, and so the things that are inside of my muscles, creatine phosphokinase, are going to start leaking out. Another thing you can see leaking out is myoglobin. That's going to become important later because it's going to clog up the kidneys and often send them into kidney failure. All right, so tachycardia, right? So one of the things, if you're just sitting there nice and calm, your blood pressure isn't that high, but I'm lifting stuff heavy and I'm cramping up all my muscles. Well, guess what? My muscles need oxygen. They need sugar. They need fat. All this stuff, right? And so what's going to happen? My heart's going to beat really fast to get my muscles the oxygen that they desperately need. The other thing is dysphasia. All right, and so if I'm having to breathe real fast because my muscles are cramping, my muscles in my throat are cramping, and everything else, it's going to be kind of hard for me to swallow right here. All right, so tremor. All right, so we talked about how blocking the dopamine receptors, it can make it look like you have Parkinson's, right? And so, yeah, then on top of that, I'm activating the sympathetic nervous system, right? You get nervous, your hands start tremoring right here. All right, and I already mentioned sweating right here. Okay, so what is going to kill this person, right? It's very important to always ask yourself, what is going to kill my patient, right? It's great that we know how to diagnose these things, but how are we going to keep our patient alive? All right, so what's going to kill them is they can have a heart attack, right? Their heart's going like this, right? Really, really fast. Well, a lot of your patients already have coronary artery disease, right? If your heart's beating 120, 130, 140, 50, 60 beats per minute, a lot of times they can't deal with that. And so they can have a heart attack, especially, with these high blood pressures, everything else. If you're having after a while you get tired, right? And so, they can't breathe. The other thing, if I'm sweating super duper heavy, I'm producing all this myoglobin, right? I'm getting dehydrated. Now I've got this myoglobin clogging up my kidneys. I can get kidney failure. The other thing is I can get disseminated intravascular coagulopathy. What is that? I get these blood clots floating all around my body. And so now I'm getting blood clots in my heart, my kidney, my brain, whatever, and that's a major issue. And so how are we going to keep these people alive? So you might have to put them on a ventilator. And so we're forcing air in and out of the lungs to keep them alive because we don't want them tiring out and dying. If the heart is beating and producing these great, kind of crazy electrical rhythms, we might have to put them on medication to help regulate that heart. And so it's not quivering. Another thing we're going to use is a blood pressure medicine, right? So just like I'm going like this, and that's going to bump up my blood pressure because my arms and so on need more blood flow. Well, what happens if my blood vessel clamps down like that? Well, what's happening is that's going to shoot my blood pressure sky high, and that's not helpful. And so I need a medicine to relax my blood vessel so my blood pressure doesn't shoot up sky high. Other things we're going to use is IV fluids, right? So as I said, they're sweating heavily, they're becoming dehydrated, but the IV fluids in and of itself is going to help cool down, right? If I have a temperature of 104 degrees and you give me IV fluids, chances are those IV fluids are going to be at 70 degrees. All right, that's a 34-degree temperature drop right here. And so that will help me cool down just in and of itself. Number two, it will give me fluid that I can sweat out. Sweat is incredibly powerful in terms of keeping your body temperature cool, right? The other thing is the IV fluids are going to have electrolytes. They're going to replace what I'm losing from all that sweat and everything else. All right. Other thing that we're going to do is we're going to help address that fever itself, right? The fever is the enemy in this situation. And so what we're going to do is we're going to give them medications to help break down that fever. So one of the things that's driving is this muscle contraction right here. All right. And so we can use dantrolene. This is a skeletal muscle relaxant, right? So instead of being able to do a level 10 contraction, if I'm only able to do a level 6 contraction, that's going to be a lot better. I'm not going to generate, or a level 2 contraction, I'm not going to be able to generate the heat that I once did. All right. Another way that we're going to treat the fever is we're going to put ice packs on them, right? And so it's going to cool them down, right? We're going to suck the heat out of their body. Now, other ways that we can treat these people is we're going to stop this low dopamine state, right? So obviously, if they're on a dopamine blocker, stop it, right? We can use amantadine. This is going to up the dopamine level in them right there. Another thing to have is they're releasing all these stress hormones, right? And so another thing we're going to use is a benzodiazepine. Because they got this excess of glutamate, and that's overexciting things, causing some stress hormones to be released. And so by blocking, shutting down the brain activity right here with a benzodiazepine, remember, those work on the GABA receptors, and so we're putting the brakes on things. You're not going to be, oh boy, no, we're going to settle things down a little bit. All right. And so, amantadine, benzodiazepines, are going to be very helpful there, and then dantrolene as well. Obviously, we're going to do supportive care, right? We got to keep this person alive. Well, how long is it going to take them to get better? Well, about 2 to 14 days, right? We're really jumping on things. 2 to 14 days. So while they're going through this thing, we're constantly checking ABGs. What's the oxygen level like? What's the carbon dioxide level like? How acidic is their blood, right? And so we're using this to kind of figure out how we should adjust the ventilator. We're using CMP. So this is the complete metabolic panel. And so we're checking those electrolytes. Why? Because when the muscles are really cramped down, they might be leaking out different things that can throw off the blood work and everything else. UA, right? Well, what do you think this person's going to be on, right? If they're in full blown, right, they might not even be awake. They might be kind of in a coma here, right? So we got hooked up to a ventilator. We got hooked up to a ventilator. We also got a urinary catheter in there, and so that urea, we can also use that to kind of track their hydration status as well. And that's also going to give us information about kind of what the kidneys are peeing out, everything else. Once again, we're worried about acute kidney failure, very common, because once again, severe dehydration and the kidneys are kind of filling up, but that myoglobin, you're not going to be able to produce pee. And so fluids are going to be very, very important right here. In checking that kidney status right there. All right, yeah, and that creatine phosphokinase, right? We're seeing how much the muscles are breaking down and everything else. And so, yeah, it also, as I said, we're using that heparin to stop them from producing that blood clots and disseminated intravascular coagulopathy right there. So even with the best management, yeah, you might have heart damage, right? So, your heart was already kind of iffy. Now you have had a heart attack. Unfortunately, those things happen. You may have lung damage because you got this DICs, or you got blood clots going there. Your kidneys didn't get enough blood flow, and so part of them died and so on. Acute tubular necrosis. If the kidneys don't get enough blood flow, it's going to be a very big issue here. And so, yeah, definitely you want to have very, very aggressive management here. And then also kind of keep your mind open. What else could this thing be? Unfortunately, neuroleptic malignant syndrome, it can often look like other syndromes as well. So they might have serotonin syndrome. They might actually be withdrawing from a skeletal muscle relaxant. They might be withdrawing from alcohol or some sort of depressant, such as a benzodiazepine. They might be intoxicated on cocaine or some sort of stimulant right there. And so it really does kind of make it hard to really jump in on this thing and treat them right away. But, by and large, as I said, supportive therapy is going to be one of the big backbones of this right there. And as I said, keeping your mind open to what else this could be, right? I don't want to be treating them for neuroleptic malignant syndrome. Surprise! It's serotonin syndrome. So not so good there. All right, guys, let's see if you can apply what you've learned here. So why would somebody with neuroleptic malignant syndrome look like they have alcohol withdrawal? I'll give you a second to think about it, and then I'll let you know what the answer is. Alright, so the reason being is with alcohol withdrawal, you do not have enough GABA receptor activity. And so GABA puts brakes on the brain. Well, with no brakes, the brain becomes too active. With neuroleptic malignant syndrome, we're stimulating the glutamate receptors. So we're stepping on the gas, right? And the brain's too active, right? So, in a sense, it doesn't matter if the reason I'm going 100 miles an hour is because I'm stepping on the gas pedal, or if I'm not using my brakes, I'm still going 100 miles an hour. So that's going to be one example right there. Why alcohol withdrawal is going to look very similar to neuroleptic malignant syndrome. Alright, so let's see, what else can we look at right here? Okay. Why would this look like malignant hyperthermia? So with malignant hyperthermia, I'll let you guys figure it out in just a second. And when you think you know, push play and I'll let you know what I think the answer is. Okay, so with malignant hyperthermia, right, your muscles are just spasming all by themselves right here. Well, what's going to happen with neuroleptic malignant syndrome, the brain is causing your muscles to spasm. Either way, you got sustained muscle contraction. And so when you do that, you're overusing the muscles. You're going to have muscle breakdown, so that's going to cause rhabdomyolysis, and that's going to clog up your kidneys. And so you're going to need fluids. We're going to need a way to make the muscles relax, so we're going to use dantrolene. We're going to have to bring down that fever. And so we're going to be using ice packs as well. And so that's why a lot of the management is similar, right? The other thing is because the muscles are using so much oxygen and so on, you're going to have tachycardia. Your blood pressure can be very elevated as well. You can have heart damage because the heart just cannot be dealing with all of that load on there. And so no surprise, high fever also. So no surprise, that's why we got so much overlap right here. Okay, so other thing is we look at this thing, it's like, why does this look like a Pheochromocytoma right here? I'll give you some time to think about it. And once again, when you're ready, hit play, and I'll let you know what I think the answer is. Okay, so the reason why this is going to look like a pheochromocytoma is because of all the sympathetic nervous system excess, right? And so what's driving this boat right here? Well, the lack of dopamine in the brain, particularly the D2 to D4 receptors, is going to cause the sympathetic discharge. In a pheochromocytoma, the problem is the adrenal glands. They're releasing this sympathetic nervous system all by itself, just releasing epinephrine and norepinephrine. The brain is releasing too much norepinephrine here because of the lack of the D2 receptor, D4 receptor activity right here. And so that's why you got that overlap here. Alright, so looking at this list again. Alright, this looks like hyperthyroidism. Alright, why does this look like hyperthyroidism here? Why are we seeing this overlap? I'll give you some time to pause it. Now I'll let you know what I think the answer is. Okay, so the reason why this is going to look like hyperthyroidism is because hyperthyroidism, one of the things that happens is you upregulate the beta adrenergic receptors. And the beta adrenergic receptors is going to make the heart beat faster. It's going to cause blood pressure issues as well, right? And why do we care about the beta adrenergic receptors? Well, the beta adrenergic receptors helps the body respond to epinephrine and norepinephrine. And so if the epinephrine norepinephrine receptor went up, in a way, it's like the epinephrine norepinephrine level in the blood went up. No, if we were to run lab work, we'd say, hey, look, epinephrine norepinephrine levels are normal, but the body's acting like the levels are really high. So it doesn't, in a sense, matter if the levels are really high because, hey, I don't have enough D2 to D4 activity, or if the body's responding like the level of epinephrine and norepinephrine levels are very high because I upregulate those receptors because I had a lot of thyroxine being released. The other thing is that the thyroxine is going to cause a hypermetabolic activity, right? The metabolism's way too fast. Well, this is going to cause hypermetabolic activity. Why? Because you got muscles contracting, we got all these stress hormones being released as well. And so that's why you get some overlap here. Well, I hope that helps you apply what you learned. And I will be making some videos on those other things that should be included in the differential diagnosis. Alright, that concludes today's episode. If you liked what you heard, be sure to click the subscribe and like button down below. And as always, if you have any questions, comments, concerns, or if there's any particular topic you'd like me to create a video on, let me know in the comments down below. Alright, well, I look forward to seeing you on my next podcast.